Hey, Jill, this is Ngazi. I'm going to send you a note through the chat function. So I just want to give you a heads up so you can look out for it.
Okay.
Okay, thanks. Good afternoon, and thank you for attending today's webinar. We're going to just put you on hold for another minute or so just to give everybody a chance to log in, and then we'll get started. Thank you. Hello again. Welcome to the webinar. Welcome to the Center for the Study of Social Policy's Prenatal-to-Three Summer Webinar Series, supported by the National Collaborative for Infants and Toddlers, a project of the Pritzker Children's Initiative. I'm Ngozi Lawal, Project Director of the Prenatal-to-Three Initiative, and we are so delighted that you're all with us today. We know that there's some folks that are still logging in, but we need every minute that we have, so we're going to go ahead and get started. We're going to be kicking off the series with our first topic, Effective Strategies for Engaging the Pediatric Community, led by Dr. Jill Sells. Before I turn it over to Dr. Sells, I just want to go over a few housekeeping items. So first, we want you to know that the webinar is being recorded so that you and others will be able to access it later. Right now, everyone is on mute, just so we can keep all of the communications line clear. During the presentation, if you think of ideas or you have reactions or comments or you have questions, we'd love for you to chat the question in the chat box on the right side of your screen. When we get to the Q&A portion, we will read some of those or get to as many of them as we can, and we'll also open up the lines so that we can all interact and hear from each other directly. So please hold your questions, but if you're thinking about how you want to formulate it, go ahead and get it into the chat box, and we'll be sure to get to it, hoping that we have enough time to get to everything. I also want to put in a plug for an office hour that we're going to have that will allow participants to dig a little bit deeper into this topic in case there are some ideas or thoughts that you really want to drill down into in case we don't have time for it today. That event will take place next Monday. That's June 10th. You should have already received the information for it. If you haven't, just email one of us at the end, and at the end of this webinar, we'd be happy to get you signed up for the office hour. So I'm going to go ahead and get us going. I'm going to go ahead and turn it over to Dr. Jill Sells, who will kick off our discussion today. Dr. Sells?
Hi, thank you, Ngozi, and thank you to the Center for the Study of Social Policy for the chance to talk with you guys today. My voice is doing something funny, so excuse me. So hello to my friends on the West Coast who are still morning, and good afternoon, I think, to everyone else. So I probably know some of you. I am a general pediatrician. I live in Seattle, Washington, and I've had the great fortune to work in the world of early childhood for about the last 15 years. And some of the biggest joys and opportunities are really all about the partnerships that we have and need to develop over time to support young children and families. And so I appreciate the chance to spend some time with you today. And the computer, we'll see if it wants to wake up and let me move the slide here. Sorry. There we go. Just so you can get a quick visual, that's me in the center of this photo in front of the national headquarters for the American Academy of Pediatrics, along with Dr. Dina Leeser, who is on the left. She's a pediatrician who now works for the Maternal Child Health Bureau in the Division of Early Childhood Comprehensive Systems and Home Visiting. and Dr. Dipesh Nafsaria, who plays a number of roles in early childhood as well, and you'll see him more later. And I cover a lot of information today and intersperse it with just a few pictures of pediatrician leaders and friends, just so you remember this is all about real people, just like all of you who are caring about children and families and doing our best to move the needle forward. So our objectives today in thinking about early childhood collaboration and initiatives are, I hope that by the end of this, you'll understand a little bit more about how medical providers might be an asset to the work that you're doing, while also understanding some of the realities of pediatric practice and some barriers to medical provider engagement. And by the end, also identify some concrete strategies to help you effectively engage medical providers in your initiatives. And I'm just going to say that I'm saying medical providers throughout most of this. There's no easy way to phrase all of these things, but I'm a pediatrician. We have a number of different folks who might wear these various hats, but I'm going to keep it simple and say medical providers for most of today's conversation. So why would you want to engage medical providers? Well, this is Dr. Amy Shriver from Iowa, standing in front of the US Capitol on a recent advocacy day. And her comment here is that every child deserves the chance to succeed and reach his or her full potential. I know that is something that all of you share as our overall goal. So why specifically would medical providers perhaps be helpful to your efforts? Well, the first one to me is the most obvious, is that the healthcare system has access to families with young children. It's really the only universal system that we have in this country where basically all children are seen before getting into the regular school system. Overall, various pieces of data suggest that around 96% of all kids have had at least one checkup in the previous year. And so there's at least one touch point that we know is happening, and hopefully many more for young children. For many families, this is really the only professional that they'll have contact with prior to entering the school system. And because we have done a relatively good job over the years of providing access to health insurance for low-income families, many of the families that we're most concerned about do also have access, often through Medicaid or the Children's Health Insurance Program. Relationships are a big part of this, as you all know. And I'm going to make some general statements throughout this presentation. And of course, that's always dangerous. Nothing is 100% true. But overall, medical providers are generally trusted messengers with most families and are generally trusted messengers in trusted community members. And those relationships and that trust can help have impact. Medical providers also have knowledge and experience with child health across a wide variety of things, from well child care to caring for acute and chronic illnesses and injuries, to behavioral and mental health related issues and oral health, just to name a few. But there is also a long history of more broadly thinking about child development as well. And so things like developmental surveillance, specifically screening, and then linkage to services, talking about and understanding things which help promote positive child development. Many doctors are involved in promoting early language and literacy, often through Reach Out and Read in the medical setting. And there's growing awareness in the field of medicine, just as among many of you, about the importance of trauma-informed care and the need to mitigate toxic stress and the adverse impact of early childhood experiences. In addition, the medical setting is somewhat unique in that it's always a two-generation approach. We certainly never see young children and families where we just see the baby or a small child, which can happen in other places where people are spending a lot of time with the child, absent from the adult, or from the family, adults absent from the child. And in medicine, it's always the two together. Pediatricians and family docs who are on the front lines are also seeing families, and lots of families, all the time. And so they see trends as they happen, and are often what we call sort of the first responders. So when the economy starts to take a turn for the worse, they're seeing families who are perhaps experiencing food insecurity or housing insecurity, perhaps earlier than others might see, or perhaps they're seeing more families that do that and they start to see these trends. So they do have a finger on a pulse of what's happening in their local community. They also have a perspective of sort of the life trajectory. I and many of the folks you'll see today and many of our colleagues are really understanding, just as you are, the critical importance of the earliest years in life. But no one is just caring for babies or just caring for infants and toddlers. They're seeing the lifespan of an individual child over the life of their practice, but also of children across the age span at the same time. So it's very obvious that when things don't go well in early childhood, they're seeing the impacts in older children. And when things do go well, they're seeing the impacts as well. So those are perspectives that are sometimes a little different than other providers might have, depending on how they interact with families or the ages of the children that they care for. So what roles might medical providers play when you think about working, excuse me, with them? This is a picture of Dr. Narissa Bauer from Indiana. And I forgot to mention at the beginning that one of the roles that I play is as the chair of the Council on Early Childhood for the American Academy of Pediatrics. And within that, we have an executive committee of folks from across the country. And Narissa is one of our newest members in that role. But she, like everyone I'm going to show today, has gotten involved in this work in a variety of different ways. We all look different. We all come from different perspectives, but we're all trying to figure out how we partner with each other and with you to improve outcomes for kids. And she happens to be a developmental pediatrician. So she, in addition to general pediatrics training, has that specialty training as well. So now let's think a little bit about the roles that a medical provider might play. I've found over time in my work in both kind of national, state, and local early childhood initiatives that people will start to understand that there may be a role for medical providers, but they're not necessarily sure, excuse me, the types of roles that they can play. So I thought it would be helpful to go through some of those. And they're listed here. This is not a definitive list, but a way that I thought about organizing this that might enable you to picture it a little bit. So as a service provider, as a contact expert, as an advocate, as a systems connector, and as a coalition or initiative partner, kind of a number of different ways we might think about this. So I just have to remind people about the sort of obvious one, is that medical providers are serving large numbers of families every day if they're in practice. And the ability for pediatric medical providers to provide quality care is the biggest platform we have for supporting young children and families and for improving outcomes at the community level. And it's been a delight, again, to work over time with a number of partners and funders who were becoming more aware of the roles that medical providers might play in this movement that we're all part of. But sometimes they sort of seem to forget that actually doctors provide care for families, and that is a place that we can leverage as well, in addition to the other advocacy and other pieces. So I just wanted to start with that one. So as we mentioned before, there's direct primary care pediatrics and all its different facets of caring for children and families. But there's other additional things that some providers are doing and many would like to do, such as delivering an evidence-based program within the medical setting. And Reach Out and Read is probably the most common example of that, which is an evidence-based program in which primary care folks integrate a new children's book into well child checkups for children up to age 5. And as they do so, they really model and share that back and forth interaction between children and their caregivers, and how that supports positive social emotional relationships, as well as the development of communication and language skills. Other efforts that people can be involved in is some are incorporating other professionals into the primary care team within their office, and Healthy Steps and Project Dulce are a couple strong examples of that, where they're working together with other professionals to support families in terms of anticipatory guidance and often helping families connect to needed resources to support their child's development and health. Other efforts include the co-location of other professional services, and this has been happening in some places for a long time, but there is more of a movement around this lately, certainly around behavioral and mental health services being co-located or integrated into the medical home setting. Nutrition services like WIC have in many places been located near in the same location, and some places have incorporated legal services nearby to really recognize that especially low-income families with many challenges would often benefit from some legal supports, and that is another example. And then a final one that I'll share is really this broader aspect of how do we incorporate community linkages and connections for families into practice and into a community and statewide system. And Help Me Grow is a really great example of an effort that is doing that across the country as well. So I just wanted to kind of lay out some of those ways that you may be familiar with or may not, that medical providers and their clinics may be supporting young children and families. A content expert is sometimes an appropriate role as well, and these are just examples, certainly not the whole gamut of what could happen, but based on the things that I've described earlier and the training and experience that folks have, there are times when going to a medical provider to provide advice, such as to a community-based health initiative, or to a developmental screening, referral, and linkage initiative, or to giving advice or input around health policies in an early childhood setting. Those could all be examples. They could also provide perspective. Ngazi, can you hear me?
Here's some hold music.
Yeah, thank you. It can also provide perspective, you know, kind of related to what I was saying earlier. So they often have a good finger on the pulse of children's true access to healthcare in their community, or a child and or family's access to behavioral and mental health services, for example. And sometimes as you're thinking about how to make progress in your community around these critical issues, just having that perspective from folks who are on the front lines and seeing lots of families might be helpful. An advocate is certainly another role that is really important, and many of my colleagues have embraced over time, just as many of you, I'm sure, have in your various roles. And so here are just a few specific ways in which medical providers serve as advocates in this space. Certainly helping to educate decision makers and funders about the issues in early childhood and around child health and development is a really important role that can be played. They can influence policy agendas within organizations, medical organizations or otherwise, to help include early childhood specific issues in those policy agendas and priorities. Can participate in an advocacy coalition. In my state around 10 years ago, we created something called the Early Learning Action Alliance, which was a way of many organizations coming together in coalition around early childhood advocacy. And so having doctors and medical organizations as part of those can be a really important strategy. It can meet with government officials or testify at committees or hearings, and sometimes having a doctor's voice as a primary voice or alongside others can be a powerful way to share your message. Some can speak at press conferences or community events. Others can write or sign on to an op-ed or letter to the editor. These all require different levels of interest and skill, but they're all things that, that I and my colleagues have done over time, and different ways that you can think about whether it might be helpful to the efforts that you're working on. The systems connector, I think, is a really important one. Those of us who've been working in early childhood systems for a long time, and those of us who are just frustrated at the overall really lack of kind of systematic progress forward for children and families, are really recognizing the critical importance of systems. And so some of the ways that medical providers can help connect the dots might include some of these. They can share what the families they care for are experiencing, as I mentioned before, from kind of their pulse on what's happening. They can provide input to systems development and what's needed. They're seeing barriers in their own office to what they're able to help families do, or from what families tell them. And so it may be a different perspective than you might have access to otherwise. They can help build bridges across disciplines. We all, I think, believe that there's a need to work together, but it's really hard to do that. And you can engage medical providers to help build the bridges to their own healthcare system and across others. They can engage other medical providers. If you're working with an individual, they may help recruit and support others and may help their own medical organizations such as the AAP and others to be connected. They might participate in an initiative as a point of screening or linkage, depending on what you're doing, or they might co-locate services with their practice. So these are things, many of which I mentioned earlier, but just encouraging you to think about it, how it can be part of an overall system that you might be building. Likewise, as you think about your efforts as a coalition or an initiative in your community, just remember that medical providers can really help provide that pediatric health perspective as you're planning in your community. They can provide a pediatric voice, which is sometimes really helpful on a steering committee or other leadership group, depending on what you're doing. And as I mentioned earlier, can really help facilitate or support the engagement of medical provider groups such as your state AAP chapter. So now that I've shared with you, a lot of the potential roles that you might think about engaging medical providers in, I want to share with you some of the realities of medicine. And some of you may know this really well, or you may know aspects of it if you have children yourself and are going into the doctor's office. But we all kind of live in our own worlds, and I have found it helpful over time as people have either expressed their frustration or just not known how to get started working with doctors, that it's helpful maybe to know some of this. So this is Dr. Marianne Woodruff, a dear friend here in Washington State, who is has been doing Reach Out and Read now for about 15 years. And I just love this little picture because it shows the excitement around the book, the relationship between the mom and the little girl in this case, and the doctor. So for the context of today's discussion, I'm just going to touch briefly on who I'm talking about today, which is folks who provide primary care to children. And in general, that includes kind of the following groups. Pediatricians, they're folks like me who go to medical school and then do 3 years of residency in pediatrics, where we learn to care for children sort of from birth up into young adulthood. Family practitioners are also go to medical school and then do their 3 years of residency, and they are supposed to be learning a really wide spectrum from pregnancy all the way through death, the lifespan. Nurse practitioners have varied responsibilities in different states, but they are often, they can be in pediatrics or family medicine, and they are often in partnership with pediatricians or family practitioners in a group practice. In some places, they are able to practice on their own, but they will often be providing primary care and well-child care. And physician's assistants usually have to work under the direction of a physician, and in some parts of the country they do pediatric related care, in other parts less. But these are sort of the main folks who might be doing those checkups and that sort of preventive type of care that we're talking about today. Medical clinics, you may or may not be familiar with the just tremendous variety of types of clinics and settings in this country in which folks might get their primary care. And understanding kind of the lay of the land in your own community will be really helpful as you think about partnerships. A inner city clinic in New York City is very different from a rural tribal clinic in Eastern Washington, which is very different from a pueblo in New Mexico, et cetera. So the geographic location, the size of the population, all of those things can drive the types and numbers of clinics that you might have in your community. But just briefly, community health centers and federally qualified health centers are generally places that serve mostly low-income families with many challenges. And so they are really good partners and good safety net sources of care in many communities. In some places they have pediatricians, in other places they are mostly family docs. Again, it can really vary, but knowing if you have these in your community and thinking about them as a key partner is a potentially really good strategy. Private practice, where doctors own their own practice, still exist. They're more rare than they used to be. And again, these could vary from a single doctor in a rural community to multiple clinics that work together in an urban community. There are more and more primary care clinics that are now affiliated with hospitals or clinic systems. In many parts of the country, there are American Indian and Alaska Native specific clinics. Those might be run by the Indian Health Service. They might be run by the tribes themselves. And there are also what we call urban Indian clinics as well in many of our larger cities. And so these clinics are trying to provide good quality health care to these populations. And they're quite variable, again, in terms of how big they are and how they look, but great partners for you to think about if they exist in your community. Military clinics are another special type of clinic on military bases or near them, which may be serving large segments of the pediatric population. Public health clinics vary. In some parts of the country, they do primary care. In other places, they don't. But knowing what exists in your community and if they are serving families, often are again serving some of the families who have a lot of the challenges and needs for support in terms of supporting their child's early development. Residency programs are the way that medical doctors get trained after medical school. And so many hospital systems and large clinic systems across the country have pediatric or family practice residency programs. And then they have clinics that are connected with that in which the residents work. And how those clinics work and how many families that they serve, it may be a significant part of the families in your community. Often these clinics will serve large proportions of low income and diverse families, but again, that is quite variable as well. Make that go away, sorry. All right, everybody. I don't know why that won't go away. Let's hopefully it will. All right. At the same time, as you are probably aware, if you read the news or listen to the news, healthcare is in the news all the time, and the healthcare environment has really been rapidly changing for quite some time. Some of the trends that we're seeing across the country involve a transition from single or group provider-owned practices to health system-owned. The rapidity of this change and how far it's come may vary, but it's definitely a trend over most of the country. There's a lot of buyouts, mergers, and takeovers, which are really changing the administrative structure of medicine and the practice of medicine. Electronic medical records are pretty ubiquitous now. They're quite variable in how they were rolled out and continue honestly to be a source of stress in many medical practices, especially during times of transition when they're just being put in place or the system's being changed. And while all of us would agree that it's great to have a legible, accessible medical record, sometimes the technology gets in the way of relationships and providers' ability to connect with families efficiently at times. So it's just something to be aware of. There are increasing sort of data expectations of medical providers related to getting paid for what they do. And again, some of that is really understandable and well-intended, and it can also have unintended consequences about the way that the practice is playing out. There is a really fast pace of change, which is difficult for anyone. And unfortunately, there is a fairly high degree of provider burnout in the medical field and actually suicide rates. And it's not unique to this field, but it is real. And I had a classmate of mine die last summer. So it's just something to be aware of. In the everyday practice of folks who are providing primary care, there are some things that impact their schedule. And again, this varies with how the practice is set up. But some medical providers have responsibilities outside of what they do in clinic, which might involve seeing newborns in the hospital or taking care of children in the hospital who are hospitalized for other reasons. Practice can be busy all the time, but there are times like Mondays and Fridays and the day before and after a holiday, during winter flu season, during late summer when there's a lot of back to school checkups. Those are predictably busier times. And harder for folks to be involved in other things outside of the office if the day there is quite busy. In general, medical providers have pretty long days with an unpredictable end to them and often no breaks during the day. The visit schedule can vary from 10 to 15 to 20, and if you're lucky, sometimes 30-minute slots. Can be very rapid paced, and you never quite know who's going to show up that day. Sometimes people are sicker than they think they are, or they think they're coming in for a checkup, and it turns out there's a significant other issue going on. So there's always been a need to be flexible in pediatric practice, and there's always a need to keep, or to try to keep, some spots available for what we call same-day access. And any of you who are parents know that when you're really worried about your kid, you don't want to wait till tomorrow, let alone next week, to have them be seen. And so there's always the need to try to have that kind of accessibility, or to just address whoever shows up in the office that day. So certainly things like injuries in sick kids are hard to predict. And there are interactions with schools and other things happening, with providers having responsibilities around things like IEPs and 504 plans, et cetera. So this is just to give you a feel for, there's a lot of things happening. So what are some of the barriers to early childhood collaboration? And I certainly can't cover all of these, but I'd like to share a few. And this is Dr. Depesh-Afsaria, who I showed in that first slide, testifying before the Wisconsin State Legislature. Again, anyone who is paying attention to the news knows that legislators across the country are involved in a lot of things that can impact children and families, both positively and negatively. And medical providers and many of my AAP colleagues are involved in those conversations and testifying as needed in these kind of settings. So this will be no surprise, I'm sure, to you as well, but it bears worth reminding ourselves that early childhood really does involve many sectors, and those sectors are really not yet well connected into a system or a system of systems. And there's no perfect way to describe this, but things like early education and childcare, family support, health, social, emotional, and mental health, parenting, basic needs, all of these things are sort of part of the world of early childhood if we want to think about and support families more effectively. There's also a lot of jargon and evolving terms in all of our disciplines. Sometimes the same terms have multiple meanings within and across different sectors. The first bullet here is just the evolution over time of words like daycare to childcare to early care and education, early learning, all different phrases we've used over time, and really well-intentioned efforts to be sometimes more inclusive or more descriptive. But at the same time, if you're having a conversation with someone who's in none of those fields, they may have no idea what you're talking about, or that you're talking about the same thing if you're using different words. Provider, likewise, right? I may be talking about a medical provider, but you might be talking about a child care provider. Someone else might be talking about a home visiting provider. So just thinking about that. Workforce development. Are we talking about how we support the workforce that we need to support children and families? Or are we talking about how we get children ready for school and then ready for the workforce ultimately? Health, it's a big term, which can encompass a lot of different things. Social emotional development, relational health, mental health, behavioral health are all terms that are probably not synonymous, but are being talked about kind of in the same conversation sometimes, and can be confusing. Likewise, nutrition, food insecurity, obesity, or ACEs, trauma, toxic stress, lived experience, you may have heard, and I think it's an important concept when we talk about engaging parents and others, but it is certainly not sort of plain language that your average parent or average medical provider or others would necessarily know what you mean. So it's just important to recognize that this is a barrier to all of us. Abbreviations. I won't go through all these, but we could go on all day with all the abbreviations that we use and have heard. And I think it's easy to forget that other people don't necessarily know what they are. So just thinking about that anytime you're tempted to use an abbreviation, particularly if you're trying to partner with others outside of your everyday work. And certainly the bigger issues that I know that we are all aware of is that the underlying inequities and challenges that exist for children and families are often really hard to talk about, to understand, and to address. And each of them have their own evolving language and terms. And these are things like poverty and immigration and racism, white privilege, intersectionality, and so many other things that are really so critically important, underlying root causes often to the challenges that families face, and that I think many of us realize we ultimately have to address if we want to have broad improvements and increase equity across the country. But these are hard and big things. So let's get back to medical provider specific barriers to collaboration, because again, there really are many opportunities and there are challenges, and I'm trying to give you a feel for both. In this slide, Nate Chamillo is my friend there in the bow tie. They shared this slide with me, and this is he with a group of colleagues in Minnesota when they were advocating to really continue the funding that was needed to support Medicaid within the state of Minnesota. And so just again, showing docs with their white coats coming together and the little hashtag "Don't Let the Sun Set" to the legislature around Medicaid funding. So I alluded a little bit to the provider schedule issues, but I'll go specifically to some that impact their ability to perhaps come to a meeting that you've asked them to come to. Generally, if you're practicing medicine, there is no time during the day to do partnership work, trainings, or attend community meetings. It's just not part of the medical culture and scheduling generally to allow for those types of things. It's rarely possible to cancel clinic time. It impacts families, it impacts other staff, and it impacts access to healthcare. So if someone's supposed to be in clinic, that's where they need to be. There are often clinic rules or needs that prevent time away. I was just together with one of my colleagues who we were hoping could represent the AAP at a particular setting, and her clinic had just imposed a rule that they couldn't make any schedule changes unless it was at least 90 days notice. Well, in my experience, many of the meetings that happen with all of these partnerships have far less than 90 days notice. And so just that rule alone was going to make it impossible for this provider to ever participate unless they just happened to have a day off at the time that someone wanted them to come. So it comes down to using vacation time or days off or time after hours for many providers to be able to participate. When thinking about a specific thing that you might reach out and want someone to be involved in, what might be some of the barriers? And I've had the opportunity to try to work with and develop networks of doctors engaged in early childhood advocacy over the years. And so these are many of the things that have come up in those settings. I'd say one of the most common is really they're just unaware of the need or the opportunity, the specific need or opportunity that you might have. And so certainly if they don't know, no one's going to step up and do that. Often there's not a trusting relationship with the person or organization who would like them to get involved. It doesn't mean that there's anything bad there. It just means that they don't know you or they don't know the organization. That's a step that we have to get past before there's a partnership possibility there. Oftentimes the role or request isn't clearly defined. Someone might say, gosh, it'd be great to have a doc do this, but they haven't really figured out what or why. Sometimes the request is not well matched to the provider's skills or interests, or the provider doesn't have the knowledge, skills, or confidence to do it. And I just want to point this out and say that, everyone likes to feel successful at what they're doing. And each of us has our skills and our interests and our areas of comfort. And if you're being asked to do something you've never done before, it doesn't matter how educated you are or whether the person asking you believes that people will listen to you because you are a doctor or you have some other title. It doesn't mean that provider believes that they can do that. So that can sometimes just be a barrier, just not certain that it's something that they could do or do well. Certainly time commitment needs to be clear and the potential for impact. People are pulled in a lot of directions, just like you are, with their own families and their practices. And if someone's asking something of you that you're not really sure what they're asking, the answer is more likely to be, I don't think I can do that. So how might we make some steps forward on engaging medical providers in community-based initiatives? And the great news is there's just a lot of folks who are involved in this. And so it is certainly possible, and lots of wonderful people out there who want to work with you and make a difference. This is Dr. Mariano Guzman in Illinois, and she is a wonderful pediatrician who is a native Spanish speaker and has done tremendous work developing the Leyendo Juntos work with Reach Out and Read about how to really specifically support Spanish-speaking families. And here she's pictured doing a community event where she's speaking. I believe this was at a library, talking about early brain development. And you'll see the neuron slides there that probably a number of you have seen, showing the growth of synapses and those connections in children's brains, and especially in those first few years. So I know I've said a lot of things about what the challenges are, but there's lots of good news here. You know that folks who work in early childhood or in care for children in medicine are just like you. They want better outcomes for the families they serve. That's why they do the work that they do. And they see the need for systems change and prevention. And many folks are already actively involved in things outside of their practice, despite the challenges. Many are willing to do something more or different. And some, like some of my friends that I've shown here today, are really involved at an extraordinary level already. So you really can increase your effectiveness in engaging medical providers if that's something that you would like to do. But if you haven't done it or you're not very connected, it will take some time and some intentionality. So some of the steps that you might take is really kind of laying the groundwork. You know, this is all about relationships. And so learning a little bit about the medical world and its culture and the language and realities, like I've tried to share a bit with you today, is a great first step. Then it's about building relationships with providers or clinics or organizations over time. I'm sure that you have folks in your community that you go to over and over that that you trust and you've built relationships with over time, and you know that you're trying to do good things together, and that together you're stronger in your efforts. And it's the same with the medical community. It's important to be sympathetic to the realities of medicine and don't assume that people don't care. That's not usually the reason they're not actively involved in the way that you would like them to be. It is really important to clearly define the role you're asking a provider to play and to be able to explain why a medical provider is needed. If it really doesn't take a medical provider, it wouldn't add that much to your effort to have this particular person do it. Maybe it's not the right request. Maybe you can think about how you can get the biggest bang for your buck in terms of the commitment that they might be able to make to you, and what does that look like? It's also important to define the type of medical provider you think you need. There are some times when really anyone who cares for children in a pediatric setting has the general knowledge that you need for the particular setting, and that's great. That means that there's sort of a wide variety of folks who might be able to do that. Sometimes you really need or want someone who can represent a particular organization or a particular clinic or hospital or something that has a special connection to what you're trying to do. Sometimes you might need someone with a deeper knowledge or skill set in a particular area of early childhood. And not everyone has that. So just thinking about which type of those things do you really need for the request at hand. And then if you don't already have relationships, it's certainly some steps about where you might find folks, either to actually work with you or to help you strategize where you might find folks. If you have children yourself, you can think about who cares for your children and ask them for ideas. Often if you look at the children within your early childhood program, sometimes you will see a handful of providers or a particular clinic that cares for a lot of your kids. That might be a place to again have that conversation. Head Starts have folks on their health advisory groups. Again, they might be someone to tap or someone to help you find someone else. You might have particular clinics or hospitals, again, where you might think about in your community. You can also connect with organizations like the American Academy of Pediatrics. Every state has at least one, what we call chapter, kind of the way of organizing AAP members at a more local level. And their purview is statewide, but they have members statewide. And so contacting the leadership there to help connect with the work that you're doing more generally, as well as to learn perhaps about particular individuals in your community. Reach Out and Read, which I mentioned earlier, is a nationwide effort, and it has kind of state or local affiliates in a large number of states. Likewise, Help Me Grow, I think, is in about 28 different states. These are examples of programs and systems that are directly connected to the medical home and therefore have medical champions that might be the partner you're looking for or might have connections with folks that might be of help. Then making your work understandable is really a big part of this. Just never forget that each one of us is embedded in the language that we speak every day, and it can be intimidating and confusing to anyone who's not in that exact same work with you. So if you want to work with medical providers, or really anybody who's different from yourself, think about how you can make it easy for them to help you. Be clear about what you're trying to do. Remember to use simple terms and avoid or explain jargon if jargon's necessary. Provide the context and background information, the things that are really important to know in order to do what it is you're hoping that they will do. And don't forget to explain your strategy or the political context. I was unfamiliar with lots of this when I first started 15 years ago, and some of my best friends and most valued partners in early childhood were the ones who said, okay, look, this is how this hearing works, this is how this committee works, this is what's happening, and I need you to go in there and be Dr. Sells, or I need you to go in this room and be Jill, and this is why they'll listen to you when they won't listen to me, and teach me what it was that was needed, or they would know the political, challenges that were happening around a particular topic, which I or other medical providers might not know. Sometimes we know the political context, but not always. And so don't be afraid to share that. I mean, people are going to say only and do only what they believe in, but you don't want to let people walk into something and kind of go off on the wrong direction in a way that's not going to be helpful to your efforts if you can give them more context to explain what the pitfalls are or what the challenges or opportunities are. A little bit of that could go a long way. In general, providers are quite variable. All of us get started just like you at one point in your life with advocacy, or we're doing something different. And before you've done that the first time, people are thinking, gosh, do I have time to do anything? Is there a topic area or a problem that I've seen in my practice around early childhood that is really interesting to me or really worrying me? But then what would I actually do? Can I make a difference if I try to do something, in addition or different from what I'm doing every day in my practice? And if so, who would help me, or who could I help? Other people or organizations? These are some of the things that might be going through people's minds. When they think about a particular opportunity, then, as you're getting more specific with them, they may be saying, gosh, is this something I'm really interested in? And can I do it? Do I have the skills to get involved? Again, how much time will this take? Thinking about whether the request or the need will interfere with their clinic responsibilities or their own family responsibilities doesn't matter. And will my colleagues in my clinic support it? Sometimes they will, and sometimes there's barriers that actively make it really hard for folks to get involved. So in terms of some tips, is really make individual or personal asks as much as possible. Be explicit about the time commitment and the goals and the impact potential for what you're doing, and then offer to help, support and coaching, encourage, make it easier. If what you're asking doesn't seem like it's going to work, is there something that is feasible? Can you offer an alternative way to get to make some progress together? Don't forget to say thank you and to follow up and let them know that it mattered that they stepped in. This is kind of silly to quote myself, but when I was first writing this, it was confusing about where I got this. And so this is my opinion based on experience, that I really think each of us needs to own the complexity of our own worlds and work to make it easier for others to understand and participate in collaboration and systems building. This work that we're doing at the national, state, and local levels is so important, and it is really hard. And so anything that we can do to reduce the barriers that we are presenting ourselves will help us all move forward. So, quick summary here is that there are many ways medical providers can enhance the work that you're doing. There are challenges that we've gone through in every field, but you can increase your understanding of this and help to address some of those barriers by better defining what you would like to do and positioning your requests. I think this is worth your time. My colleagues are generally caring, good people who want the same outcomes that you do for children and families. And I really believe that only by working together across disciplines will we do what we need to do, and kids are counting on us to do it. So these were our objectives, and I know we're getting close to the end of time. So hopefully you've learned a few things from our conversation or my speaking here today. And I'm going to leave you with this photo again of Dr. Chamillo. If you Google Nathan Chamillo and this article in the Star Tribune in Minnesota, you'll learn a lot about one of my fabulous colleagues. And this is really bridging, you know, both advocacy, media, and what he does every day in practice with children and families. And this is what it's all about. So thank you so much for joining us today. And I'm going to turn it back to Ngozi.
Thank you so much, Dr. Sells, for taking time to talk with us today. You shared a lot of important insights, and including some of the barriers and opportunities for collaborating with medical providers. That was really terrific, so appreciate that. We want to move into our Q&A portion, and really Q&A is just, you know, the formality, you know, in terms of what we call it, but we'd really like this to be a conversation. It'll be really brief because we're almost at the hour. So this is probably a good time for me to shamelessly advertise our office hour, which will take place next Monday, June 10th, from 1 to 2 p.m. Eastern Time. So you can register for that and be able to talk more with Dr. Sells and with some of your colleagues. So we'll take a few questions now, and then we can plan to continue this conversation next Monday if you have the time. So I'm going to go ahead and unmute the lines now. I think there are a few people who raised their hands in the chat function, so didn't actually pose an actual question, but raised their hands. So now that you're unmuted, fire away. Can we confirm that the lines are unmuted? Jill, do we still have you?
You do.
Okay, good. Okay, we got a question. So a question just came in, and I won't read all of it because it's pretty lengthy, but in essence, the question that's being asked is, can you talk a bit about a situation where it was difficult to bring a medical provider into a conversation, but because of the strategies, some of the strategies that you talked about today, you were able to bring that person along?
I hear a lot of background noise there, sorry.
So Erin, could you mute everybody again while we have Dr. Sells?
Thank you.
Sorry about that. We should be good to go now.
Okay. Yeah, I think certainly specific coaching, like when people are testifying, for example. When it comes to coming to a government meeting or a government hearing, for example, which is sometimes part of, or even a local community conversation with partners, that is something that the average physician maybe has never done before. So just giving a little bit of background, like this is who's going to be there, this is what's going to happen, this is what we're hoping to accomplish, and here's the role that we want you to play. Just being really clear about that, then people understand what's expected. And if they know that it's just, hey, you're just there to listen and share your perspective from what you know every day in practice, that's all you need to do, that's great. Then people will say, okay, and it removes a lot of the stress from the situation. If it's something more specific that is very structured, like you're going to the legislature. I remember the first time I ever testified before the legislature. It's very intimidating and had no idea how it worked. But then I was there for a variety of other reasons, and I kept seeing, you know, childcare providers and family members testifying, and I thought, well, gosh, like if, you know, this mom of a preschool student can get up there and testify, I probably can learn how to do this, but everyone's nervous about how to do it. So then it's just the specifics, like help, like you have 60 seconds and they'll call you up and you'll go in the first row and there'll be a light and you can read your testimony. It's okay. It's literally just that coaching for an unfamiliar situation. Those are a couple different answers at that. And And mostly just remember these are regular people. They're just regular people who get intimidated like everyone else. And if you can try to have a conversation so that they understand what they're walking into, I think that's really the biggest lesson.
Great, thank you for that. So another question's come in, and it reads, do all pediatricians and health professionals participate in grand rounds? And is that an opportunity to connect with them or share information they can take back to their practice? And if you could just explain what grand rounds is for those of us who don't know.
You bet. At major medical centers and medical schools and children's hospitals, there's often something called grand rounds. It tends to meet once a week, and it is usually a formal lecture type setting at a hospital most frequently. And if it's a pediatric hospital, then it's always about pediatrics. And so it is a formal thing that many people in training and people from the community will often try to go to. Certainly not everybody. But like here in Seattle, it's 8 o'clock to 9 o'clock on Thursday mornings at the Children's Hospital, and it covers the whole gamut. So in the calendar often, in some places is set really far in advance, and sometimes they have outside formal speakers, and so it's usually a pretty formal setting. And sometimes initiatives and others who are not in medicine can speak in those settings. How hard that is to do is quite variable, but it's certainly worth understanding how that looks in your community if it exists, and who's in charge of how that happens and whether there might be a role for you. And usually it would be, a doc that would sort of help you get in that door, right? So you're more likely to have success in that if you were doing something that already engages physicians, and they can help sort of be a champion to kind of get that topic to come there. So it's certainly worth exploring if you are usually an academic medical kind of setting.
Great, thank you. Another question has come in that asks, can you suggest some strategies when working with a clinic where some providers are interested in working with your program, but some are not? Or where most of the doctors are interested, but perhaps the administration is not?
Yeah, really good points. To move anything in a clinic, like many other settings, it's going to require both the medical providers wanting to do it and able to do it, and then kind of whoever's the administrative in charge part of how that clinic works. And sometimes those are very different things. And so the main thing is within the medical part of it is the medical champion. So you, as the person outside the clinic, are probably not the one who's going to be able to get the folks who are not as engaged. But if you cultivate those who are interested as the medical champions and help to support them in their ability to bring on their colleagues, that's generally the approach. So certainly like a clinic that does reach out and read, for example, has an identified medical provider who's the medical champion. And part of their job is to kind of rah-rah their colleagues around it. And I think that sort of approach is what is needed in most cases. It's very hard for someone outside of a clinic to change the internal culture. You've got to get to someone who wants to do that. And so having that person do that. Then sometimes though you can be helpful to the medical providers who are trying to get their administration or leadership to buy in, or vice versa. Right? So sometimes there is a non-medical provider who thinks something would be a great idea and the medical providers aren't on board. It can work both ways. And so if you have a relationship with either side, you can ask if there's a way for you to be helpful, because sometimes you can be part of a presentation or a conversation, but it's usually someone inside who's going to help you understand what that opportunity is and help make it possible for you to be part of that. And if you come at it as how is the thing that we're talking about going to be helpful to their families? How is it going to make their job easier? And then how can you help them have that happen? Approaching it sort of with that kind of perspective is usually the best chance of success.
Thank you, Dr. Sells. So we are unfortunately at the end of our time today, but the good news is that we'll have an opportunity to talk a little bit more and dig in. And I would just like to say that at the beginning of the office hour, I think what we can do is just go through the questions that we didn't get to today so that everybody gets a chance to hear from you. And that session will be a lot more interactive. So just a plug for that for next Monday at 1 o'clock Eastern Time. Dr. Sells, we really want to thank you again for your presentation and your time today. We learned a great deal, and let's keep the conversation going. Thanks so much, and everybody have a good rest of the day.
Thank you.